This 18-year young male has sustained injury, has facial injury, had twisted his right knee 4 years back with complaint of pain and instability. 1 month post injury MRI was done, which is suggestive of ACL and lateral meniscal tear. After 9 months post injury, patient underwent surgery. The injury surgery 9 months post injury has undergone arthroscopy, ACL reconstruction using hamstring graft, and meniscal repair was done using all inside technique using 2 sutures. And immediate post-op period was uneventful, and patient has undergone regular PGO and rehabilitation for 9 months, and he has returned to his sports too. But he had a complaint of sudden onset of knee pain during his sporting activity. Because of that, he has to halt the sports activity, and patient was consulted to various doctors and was advised for regular PGO or PGO and pain oral medications was given. However, the patient didn't improve symptomatically. He had persistent instability in his sporting activity, so he visited to our hospital at B&B 4 months back with some visiting complaints of pain and eating sensation during sporting activity. Also, he had instability episodes during the sports and occasional locking too. On clinical examination, on inspection he had a quadriceps atrophy of 2 cm on measurement compared to the contralateral limb. And on examination, medial joint tenodesis was present, and there were minimal diffusion was present, and uniform diffusion was present over there. If my views yes, minimal diffusion, and total mobility was intact. The active range of motion was about 125 to 130 degree, and extension was, and passive range of motion was about 140 degree, and extension was about 10 degree, which is comparable to contralateral limb. And on anterior lateral test, he has increased extension, plus input was hard. And anterior and posterior drop test was done, which was negative. And varus and valgus stability test also has been done, which is negative. Also, pivot has been done, which is negative. And on examining the manual test, the click was spread on the finger on the meniscal side, meniscal side. After the examination, we performed the radiography, plain radiography, X-ray has been done, which is not significant. There is intervention in the well placed on the lateral femoral spondyli, and a graft only was normal. And this MRI in T1 and T2 sagittal images, the graft optic is good. There is a well-defined fibers have been seen of newly reconstructed fascia after the surgery. And the meniscal tissue has been lost from the posterior medial corner of the knee. You can see in this image, and which is confirmed on the coronal image, where the component of the medial meniscus have been seen near about the notch. So our plan is to undergo the diagnostic arthroscopy. After pipe testing, we will assess the meniscal reducibility and repairability. Whether the meniscus is repairable, then we will repair the meniscus using outside and all inside technique. If non-repairable, then using the perennial graft in the hamstring has been already been used for ACL, to expand for meniscal autograft transfer using the perennial graft. And the isolated meniscal repair would be augmented with the fluid cloth. And finally, the knee will be augmented with the lateral extra-articular tenodesis procedure using Allison's technique. Now we will proceed to our surgery.
So are we done with the history, please?
Yes, Dr. Joshi.
So you see that this was a very basically young guy, a sportsman actually. He's a now no more a professional sportsman. You have done an ACL reconstruction. His ACL looks pretty okay. Little bit on the higher side, but ACL looks pretty okay. But he had a displaced bucket handle here. Okay?
Okay.
So he was actually the previous, we had two anchors, one here, the horizontal mattress was applied, one was back there. So it was quite a huge tear, but it was fixed with only two anchors. Probably that was inadequate fixation.
Okay.
That was the reason for, failure of the meniscal repair.
Okay.
So our plan is to repair this, augment with the clot, and do the meniscal repair, and along with that now we'll do a lateral extra-articular tenodesis. Is my plan clear, Ravi Mittal sir?
Everything is clear except the lateral tenodesis. Why are you doing here?
So can I ask the faculties, how many of you will do a lateral extra-articular tenodesis in this case? Show of hand and just to know that how many of you will do lateral extra-articular.
See, the faculty is gone out to have a cup of coffee. So,
Yeah, Amit, I'm Dr. Sunit. I will definitely do a lateral extra-articular tenodesis because the risk factor are quite huge, less than 25 years age, soft tissue graft used for the ACL reconstruction. I think, you do only good with the lateral extra-articular tenodesis. No harm in doing it, adding it. With the meniscus, large bucket handle tear of the meniscus as well, so that makes the knee even more unstable. So I think it's only a wise decision to add a LET.
Yeah, absolutely. Number one, Ravi Mittal sir, this is a revision meniscal repair.
Okay.
So I want to give everything possible to this patient so that there is no tear of this one again. And if this revision also fails, then there is a very less chance of less possibilities we have. So here I am going to augment with the fibrin clot, and then after repair of this one, multiple sutures, stable repair, and then I will come back and do a lateral extra-articular tenodesis.
Okay.
So,
Okay. Can we see the outside view?
Sorry.
Any question, please?
Yeah, I'm Sunit. I wanted to know what is your prediction about repairing of this huge tear, bucket handle tear. What is the chances of healing?
You see, the chances of healing is pretty high if you go to recent literature, 70% heal. As far as the revision case is concerned, the healing rate is little lower than this one, but this is, you see that this is a big bucket handle, this meniscus looks pretty normal, so it's almost, not good to sacrifice. I will not say it's crime to sacrifice, but I would definitely love to repair this.
Okay.
Sir, Vivek here,
Amit,
sir.
yeah, Amit, sorry. Amit, Dr. Sudip here. Are you planning suture shuttle technique or your AJ sutures here?
I'll do everything right. You'll see here. I'll try doing everything.
Okay.
Okay. So
Sir,
let's
Vivek-
go ahead. So here,
Sir, one more question. Sir, Vivek here. Sir, what is the pivot shift grading in this particular case?
Grade 2 plus. It was grade 2 plus. That was another reason why we wanted to do. I'll not talk about what has happened, but his ACL is intact. To my liking, it is little too vertical for me. Little vertical. Otherwise, the ACL looks pretty intact. And it is little lax. That's why another reason to add the Allison procedure.
Okay, so it's double fold. One is the inadequate fixation, second is the pivot shift that is still there in spite of the good ACL. Okay.
Agree. For nowadays, if you see that for very young guy, I would have definitely done with meniscal tear with ACL tear, this type of bucket-headed tear of the medial meniscus, I would have primarily done a lateral extra-articular tenodesis in a 21-year-old. See, the primary surgery was done at the age of 21 of this patient. So in 21, very active sportsman, it was lateral extra-articular tenodesis for me at the time of index surgery. So since it was, I presume that it was missed that time, I'm going to do it again.
Hi, Dr. Amit, Vikram here from the audience. Sir, have you checked for the ramp in the posteromedial compartment?
Yeah, we have done that. You can see from here also, there is no ramp, but it's a big bucket handle here. Give me a probe. So there is no ramp. Let's cut it short because here I am going to show you so many things. So let me go ahead. You can ask me question in between. So what I have done so far, I have done a good diagnostic arthroscopy. There is no ramp. His lateral meniscus is normal. His cartilage is perfectly all right. We have done pre-operative investigation. His alignment was correct. His X-ray were right. His ACL was intact. If you have seen the MRI. So what we have done so far is we have passed on outside in reduction suture. You see that this fiber wire is a reduction suture. Then we have passed two proline suture here. So this is a new technique which is already been accepted in arthroscopy just to do an augmentation of the fibrin clot. Can you see the outside view?
Can you enlarge that view?
Yeah, can you show the outside view here, please?
Yeah. Yeah, we can see that.
Can you see the clot?
Yes.
So you see there is a proline which is coming from outside in, from outside, and then it has come outside the cannula. This is a 3 cc cannula that we have made. 3 cc, and then now this is attached with the vital suture. So now we are going to shuttle this clot inside the joint. Okay, so that's why it is called pull-in technique of your fibrin clot. Give me a probe. Now you can start pulling Rohit. Dr. Rohit is my assistant, who has been assisting me for a very long time. So okay, so you can see that now the proline is pulling the vital. Can you see that?
Yes.
So this is underneath this outside. So this is pulling the vital. Please pull. So the proline has pulled the vital. Now vital is outside. So now the proline is disengaged. And my colleague will pull the vital now. It will deliver the clot. See that clot is going along with that one.
Yes.
See?
Yes.
The clot is sitting at the tear area.
Okay.
So now I pull this outside in. This is a reduction suture. Outside in. So it is putting the clot at tear area. Can you see that?
Yes.
So this is a pull-in technique, and then the vital which is attached with the fibrin clot will remain there till we do all the repair work. Okay? So that it will stabilize, the vital will stabilize the fibrin clot there, and then we can freely do our repair work.
Okay.
Okay?
Yeah, nice
Good.
technique.
Take it out. You just hold this reduction suture. Okay, so we will start with the repair. So now some of you can sew. I will start with the AJ stitch. Give me a probe. So that extension, I can see the posterior part. You see the tear is right from here.
Yes.
So ideally, the literature says that for posterior horn, you go from anterolateral portal, but here it's quite far from the vascular area. The vascular area is somewhere there. So I can use all inside technique here. Okay?
Okay.
So you give me some more. So my friend Dr. Rohit, who is with me from the very beginning of this, development of this AJ stitch. So he will show you how to prepare that AJ stitch. Okay, conventional AJ stitch like that. So you see that there is some fibrillation of the. Let's change this cannula to a cotton cannula. Yes. Okay, this guy goes. So I will describe. They will show you by. Can you see outside video?
Yes.
Look at the okay. Cannula मलाई अर्को चुकी एज स्टिच देखो जस्ट लेट मी चेक व्हाट इज माय डायरेक्शन अलिकति बेन्ड गरेर गिभ अ 15 डिग्री अफ बेन्ड गिभ 15 डिग्री अफ बेन्ड so if you what you are seeing there both views
Yes.
okay so just focus on the inside view I just want you to for for the purpose of demonstration this is a slot this is 1.5 millimeter diameter slot where the anchor will be attached and then we'll pass anchor here you'll see that now I'll ask Rohit to demonstrate how this anchor is made on the table and then it is fixed into this deployer okay data focus garnus so this is 120 excuse me 120 and 20 actually packet खोलो ना देखो ये packet ले रहा oh AJ stitch so ये ला देखो कितना ले रहा so this is AJ stitch so it has number 5 keyboard and 220 suture with needle so you can see that the same suture can be passed इतना देखो आगे देखो so this is number 5 keyboard and we are passing with the needle through the number 5 keyboard
Can you enlarge the outside view? Can you enlarge the outside view?
outside view खुलो देखो outside view
को बड़ा कर दो.
क्या बोला outside view खुलो देखो बोला
Yeah.
Yes, we got it.
yeah okay can you see now
Yeah.
Yes.
okay so you see he is passing from this one and the core suture of the keyboard will come out which will make way to the suture and then there is a mounting effect okay
Okay.
so 1 and 2 so one will require 2 anchors like all inside technique और ये तुम्हारा 50 डिग्री बेंड करेगा
This is ethibond over vicryl, is it?
not vicryl sir orthopod
Orthocard. Okay.
okay quick let's do it fast so that the other guy can just make it on the other one so this is preparation is little time taking unlike fabricated all inside technique but all inside technique here costs 40,000 rupees and the hour anchor will cost you only 2,500 rupees so that is the difference
Very nice.
if Vikram remembers I have demonstrated a video demonstration in his meeting now I am demonstrating trying to demonstrate it live okay just to take less time there we go. So the anchor is now ready to be deployed can you see that
Yes.
so here we go it requires a cannula so I am going through the cannula and you see I have made a bend here
Can we
I
have
have made a
that?
bend here so this was his earlier suture area probably so I'll go through that only okay
Yes.
take it out so the first is passed
Okay.
now this quick so your wire ko dekho na the second anchor is being now loaded So this is the second anchor. The second anchor goes to the capsule.
Okay.
So this goes to the capsule, okay? So here, now the loop will go, loop on. So you see that the repair has been done. Can you see that?
Yes. Very nice.
So another little challenging here is you should have a knowledge of shoulder arthroscopy so that you can pass some half inches. So we have done a pull-out strength of this technique. This is all suture, which is as good as the other sutures. Ready para.
Dr. Amit,
Yes, sir.
where did the first anchor end? Beyond the capsule or just next to meniscus?
Both will go beyond the capsule.
Capsule,
sir.
okay.
Beyond the meniscus will not hold.
Yeah,
Both
well,
have
that's
to go
all.
beyond the capsule.
Okay.
Needle काटेर देऊ न बाबू मलाई needle काटेर देऊ so that it doesn't tangle anywhere, so that we can demonstrate nicely. This is first time in the world this is happening. So you see, I presume why previous surgeon has put just 2 anchors is because of the cost. This was a big, tear. Most likely because of the cost, he just compromised the fixation, I presume. Because it would have required at least 5, 6. So you agree this? All inside just 2,500.
Sir, I have a doubt. Vikram here in the audience. Hello?
Yes.
Can you hear me? Sir, great repair, great fixation, but I have one fundamental issue that as you have reduced the meniscus onto the capsule, if you notice, the tibial plateau has been lay bare. So the meniscus is in a way extruded from where it ideally speaking should be. Do you think that has any consequences for later on?
Yeah, I absolutely agree, but you see that this is because of the pipe crusting we have done, this has opened widely. So if you go inside, it will come and close this. You see that? And then when there is a pressure, it will come back. So this is because of the pipe crusting, the lower capsule is pulling it out.
Hi sir, this is Ankit.
Yes, Ankit.
Sir, do you posterior root is also deficient here?
Here?
Yeah, in this
We
patient.
checked it out, you can see that it's going way down. So we check that from other side, okay. I'll probe and show you. आपको दो मैंने खोला ना okay. So here I'll show you how I apply a sliding knot. In that one, I did a half inches. Now this can use. This is a little different modification of this one. It is not published yet. So we started getting a trial of this one. So by the way, this is my 130th case of AJ stitch today. we have deployed around 450 anchors by now. This is made by here only on the table. And then so far for last 1 year, we don't have, still don't have any failures. Okay. This good. This. Yeah. So you see that now this is little different design. So I'm going to use a sliding knot in this one. You cut a little, cut a little. Sorry. Knot pusher, make ready please. So this is our new modification of anchor. And then it is now again is going to be made by Chinese friends now. Unfortunately, the Indian market is so big, they don't want to make this anchor and the device. Give me the knot pusher please. So this, see this, the sliding knot is going there. So it makes your life much easier. So knot is locked. So nowadays, as Vikram was saying, how it looks at the time of surgery is not that much important, because we have seen peroneus has been put here and then it has acquired a beautiful shape. So here what we are doing is we are keeping the same meniscus. It's speedy. So you see the difference between the previous one and this one is the location of the knot. Can you see that?
Yes.
In the previous one it was in the meniscus and now it is in the capsule. Now this is just in the capsule.
So what difference does it make?
It makes, I assume that it makes little difference because in the meniscus it will rub between the condyle and the meniscus and this is right at the capsule, hopefully it will not rub. I think it's getting rolling down because of the repair, because of the quality of the tissue as well. It will come up. You see, once we finish the repair, it will come up. It looks like rolled down, but it will come up. Okay, so now I change my scope to the anterior and then go to the camera. Another anchor ready, please. Okay, take out the chopper. Yeah, ready? Good column, good design. Fingers. Fingers. Okay. So now I have changed the direction now. Okay, so first I'll go into the meniscus. This technique will require a little different. Okay, it out. Load another one. I think so. No problem. It's good. So you see that the sutures are holding the cords as well, and this our technique makes sure that your cord is right there when you are repairing. Otherwise it's very difficult to keep your cord there. You have to pass your anchor, not tighten it, and then put the cord. It's very difficult. This technique, pull-in technique, makes it more easier. You agree Do you agree that this looks
Yes,
very
yes,
easy, your
yeah.
knot is there, you are doing the repair? Keep going, just go. And then see what I was talking about, the difference of this and difference of this one. You know, this is the knot is at the capsular side, here knot is at the meniscal side. Probably to my liking, I was little overzealous of tightening this, that has made, which Vikram doesn't like. If you know.
Sir, actually in the long run it doesn't make a difference at all because this whole this whatever knot is going to be synovialized. So wherever it sticks, it doesn't matter.
I understand, but just to tell you that with this type of knot, we have few cases of squeaking of the knee joint, you know. In the initial 3-4 weeks, these people have squeaking. So, since we started this putting the knot on the capsular side, this squeaking has not been reported. This capsule is very big, okay. So if the angle pulls out, we have to put it again because the capsule is very flimsy out here. Maybe it has gone to the ceiling old one. Okay, hold this, scope. Very hard, okay, yes. So I'll just punch that red. So like in shoulder surgery, the post has to be the one which is in the capsular side. So by now we have, spent 1,20,000, but we are still within the range of 7,500 rupees. One more, yes, one more. Here you don't need to do a conjugacy. You can apply as many as possible, just 2,000 rupees. MPR, by the way. पता देखा है सर बोलिए बोला ऐसा देखा है यस और more and then we'll be done with the Miniscal repair.
Amit, Dr. Naveen here. As you have demonstrated that first you pass through the meniscus and then another one goes into the capsule. Can we do reverse? First through the capsule and then another through the meniscus so that this sort of extrusion might be reduced?
Extrusion of what?
It appears a little bit meniscus going away from the tibial plateau part.
No, it will not make any difference.
Okay.
The only difference is if you go into this capsule first, your knot will be on the meniscus. Okay?
Okay.
So now we are going to do remove the reduction fiber wire. Take this out. This is not required anymore. Okay, reduction suture is out. So we'll put one here and then you finalize if you need this thing or not. Thank you. So in the back table, my friend is still preparing this. So, P one here, if it is required, I'll check what it will be. P is not required also. You see the strength of fixation is fantastic. Okay, so Quentin plot is there. Probably one I put here, maybe one here also. So I go little in the tapered size because it will give you a circumferential compression. Okay. So there is now, we are developing a AJ stitch 2 which is even smaller than 1.8. We are coming up with the 1.3 for the mosquito so that you hold, we do not dislodge. एवढा असे बनवला एवढा इथं सुरू आला म्हणजे how many times 26 we have 20 minutes left. I would definitely love to show you, if time permits, show you the Ellison's technique, which I am very proud of nowadays. Ellison's technique of lateral extra-articular tenodesis. This is great. Notice? Which is going to be the next part. आपको रेडी? I'm getting older, not able to identify. So I am sorry, Sudip Bhai, I can't show you the suture subtle technique that you wanted.
Yeah, no. That I have already seen it.
Yeah, you have already seen, so that there is no point showing you that again. So this is going to be the last one. To enjoy AJ stitch.
Suture subtle we use the epidural needle from outside in technique.
Okay, pick it up quick. Put another ones. So nothing is prefabricated, everything is made here. Only the device which has been made by now Nepali company. The Indian company refused to make this device. Although when I started, it was made by the Indian company Biotech, but they refused to make this device, stating that it will damage their business of all inside device. So they are not making it. We are having a different lateral method of making this device now.
You'll be too villain to their business.
Yeah, that's why they never wanted to make it. They frankly told me that, sorry sir, even if you want few more, then they can make it for me, but not for the selling purpose. I wanted to sell this to at least for Nepalese people, Indian people, Indian colleagues are now very rich. They have all the insurance policies covered up. But you see, my patients, what is?
Dr. Amit?
My 90% patients, they are not insurance covered.
Dr. Amit?
Yes, sir, please.
आपकी इंडियन से क्या नाराजगी है भाई?
Sorry, sir. Can you be little louder?
हम लोगों से क्या नाराजगी, हमें नहीं दोगे?
आप इधर से लेके जाओ सर तो.
ठीक है.
No problem.
Grateful, grateful.
You may be soon banned in India.
I have friends like,
Maybe
Vikram, who is, very brave enough to call me in a meeting of innovation and allowed me to demonstrate a video technique. I am so privileged to demonstrate him the live, so it was not limited to the video technique only.
Let me make a prediction today. I never make a prediction.
And more importantly, sir, you won the best presentation award also.
Yeah, thank you, Vikram. That is because of you only, no?
Dr. Amit Joshi,
Yes, sir.
can I make a prediction today? I never make a prediction, but today I'm making it. This is going to.
India-Pakistan war? I am sure it is not India-Pakistan war.
क्या बोल रहे हैं?
India, Pakistan war.
नहीं.
Please, sir, then make your prediction.
This idea is going to catch up all over the world, and sooner or later it will be recognized.
So I have been using this for last 1 year.
No. There'll be somebody who's going to make it for you on a commercial basis also.
Thank you very much, my friends. I do little bit of training in this one, punch. I'll come back and then do a punching of this one. So I'll go to this one, little bit of this requires little bit of punching. Otherwise, this is the repair. You like this repair, sir?
Yeah.
Yes, very nice.
So I'm done with, and then you see the plot
Very nice.
right there at the repair side. So no hassle in keeping the plot at that position. Now we did a circumferential suture on this plot, and the vicryl can now be removed. You can pull the vicryl out. Yes. Pull the vicryl out. So you can take out the vicryl outside without hampering anything. So inside there is nothing. You agree? So everything all fixed.
Very nice.
Any question on meniscal repair? Now after this repair, earlier when I started, I was little in doubt that should I repair this or not. But once you repair, you always feel that this meniscus are beautiful stuff. You repair, they look really nice after this one. After the repair. Okay, alright.
See, meniscus is a viscoelastic structure. So it changes the shape according to the force that is applied on it. And when you put it back,
Sir, I have shown using hamstring, and then hamstring acquires such a nice triangular shape.
yes, because even tendon is like that.
This tissue. Yes.
So,
Thank you very much for the meniscal repair. I'm sure suffer.
yes.
I'll go to the lateral extra-articular tenodesis. So, Ravi sir, you would have done LET or not done?
Don't ask me this question in public.
I would definitely do a lateral extra-articular tenodesis. So I'm going to that one.
Okay.
So if I am over time, I'm done with the meniscus, which was my primary job to show you. First time in the world, the AJ stage, that was in the workshop as well. 8 hours. So now I'll go to the lateral extra-articular tenodesis. I do a Ellison technique. 8 hours. Mere pass hai. More than that. Zero position. AJ anchor batao.
Dr. Joshi, can I ask you one thing? Can you test the laxity once again before going for LET?
Yes, sir. Look at this.
Do you find any change?
Yeah, it has now more stable compared to that one.
Okay.
That is understandable. After repairing the posterior wall of the middle meniscus, this is more stable. It is more stable. I can see a solid harding point, but still there is no harm on doing one small lateral extra-articular.
Okay, that was the only message.
So you see, this is Gerdy's tubercle, and this is the I find this Gerdy's tubercle, just a small incision along the Gerdy's tubercle. ये की पुरानी टाइप DOP में साढ़े लगाते सूचर काटे बनाए. So nowadays I stopped receiving, offer to travel in India as well by the company because I don't use their marketed, well marketed all inside technique. Forceps.
ये पॉपुलर हो गया तो ह्यूज लॉस ह्यूज लॉस है भी पॉपुलर हो गया
Huge loss to what? The company?
I mean the company.
That doesn't matter.
So I do Ellison's technique. I have a debate. My own colleague, he doesn't like this. Vivek Basukala, he doesn't like this Ellison's technique. But over last 1 year, we have done around 70 Ellison's technique. It's a beautiful technique, very simple one, not very constraining, like ideal for this type of cases. So Vivek, if you are there, whenever you want to stop my transmission and then start with the scientific program, you are okay. You can do that.
No, you are part of the scientific program.
I'll be there, but my talk.
No, this live surgery is a part of the scientific program. That's what I'm saying.
But Ellison was not part of the live surgery, so it was. Since I have little more time, I just want to show you how I do the Ellison. So you can feel that this is the Gerdy's tubercle. So this is your IT band. Go down. So all of this IT band, I'll make a incision knife, please, deep man.
So we still have 10 more minutes, so we can still proceed with live surgery.
I can finish.
Live surgery.
I think.
And audience, don't be carried away with Ellison procedure. Lamar's is way better. I'll show you in debate.
Younger people, they do so many things, which will be replaced by the older things. Why I want to show you this Ellison technique is because here I use a easy anchor now. Okay? Coffee, do you have coffee for me? So this is 1 centimeter thick.
Really?
Raju Bhai, he doesn't like, I remember debating with him once, he doesn't like any LEDs. He's not around.
Dr. Amit, this is Raju here.
Yes, sir.
So I recently saw this modified Ellison in PKC. See, we'll have to agree that LET is a non-anatomic procedure. The least non-anatomic variant of LET is probably this, the modified Ellison.
Agree. Vivek is around or not?
The most non-anatomic obviously is the modified Lemire, and somewhere in between is the Arnold and Coker modification.
I hope Vivek is around because he is debating with me tomorrow. I am debating for a non-anatomical procedure,
So there is nothing like little anatomic and complete anatomic. If it is non-anatomic, it is non-anatomic. So that is my concern. Let's see.
Let's keep it for tomorrow, Vivek.
Yeah. Yes.
So you see here the same technique like Lemire, but you don't detach from the proximal, you detach from the distal Gerdy's tubercle and take it back and put it to the Gerdy's tubercle.
The one obvious advantage obviously is that there is no collision with the ACL femoral tunnel.
Perfect.
The biggest irony obviously is that you have done a very nice and anatomic ACL and you want to protect it with a non-anatomic LET.
I I agreed at the very beginning. I said that to my liking, this was a not very perfect anatomic ACL seizure. ACL reconstruction. To my liking, the tunnel was little vertical. The femur tunnel was little vertical. And then he had, pre-operatively, he had grade 3 pivot shift test, grade 2 plus pivot shift test. So that we can show the LCM. We have to show this.
Dr. Joshi,
Otherwise, during Pasupala, we will say tomorrow that how bad we demonstrated the LCM technique. But we have to show LCM. You can see the LCM now?
Yes, sir, yes.
Outside picture. Did I here see the LCM?
Yes, sir.
Okay.
Not so bad dissection, sir.
See, sir?
Sir, I just have one apprehension with doing an LET in isolation after a previously done ACL reconstruction. Normally an LET and an ACL reconstruction done together have to be at a particular tension. So you basically do your ACL tunnels, you do your LET and then fix your ACL. So don't you think just doing an isolated LET in a previously done ACL could in a way over-constrain the lateral compartment and not, can create issues later on?
Very good question, Vikram. But that is the reason why I say do Ellison technique, not Lamar. If you see this Ellison technique, this doesn't constrain. That is the beauty of this Ellison technique. The biomechanical study has shown, and then you don't need to put it in Ellison. In any position of the knee. So that I can pull that side. So rotating. That's just what I'm doing. Okay. So you see that it has gone under. And then it is the pulley mechanism that will work. In flexion it is straight. When you do extension, this pulley mechanism that prevents this. It comes from posterior to anterior, this prevents internal rotation. Did you see that? Come down, come down. And then done. One anchor and fix with the anchor. And both the surgeries are done. Come down. Yeah. So you see, whole aim is to put it there only. In the anatomical position. You see that? In the same position from where you have detached. Drill down. Drill down. What boss piece down? Oh. Boss piece down, no? Sitting or a time some piece of it. Just 6 minutes left. Number please, number. Can you have drill now? Should I go? So this is, I am going to put again, make and use, if you have read my paper, they can use all suture anchor now. There is not meniscal repair, AJ stitch, but this is AJ anchor. So this is again a new modification that we use a number 7 ethibone and pass to number 0 fiber wire. Again very cost effective. Okay? Okay? यहाँ देखो बोला क्यों देखते एक्चुअली डिप्लॉय कर दी छोटे कर दे okay done so see that now the anchor is deployed. Next thing is just to there two double loaded anchor, needle free needle quick. So I do a Mason and Allen type here. I'm nervous. So many my teachers are watching. यसको जोडी खोज खोल घुमेर आएको सक्छ देऊ मलाई फेरि देऊ घुमेर यसको जोडी खोज देऊ निडल कोही देऊ न निडल देऊ निडल क्विक load so poor country do not have a liberty of having a two colored suture come on क्या बात समझ रहा है ये तो समाप्त इसको जोड़ी दो लोड इतना धागो कसरी घुमाइरहेछ यो घुमाएको उता माथि लैजाऊ न हो so suture management is very important when you are using multiple suture it should not tangle do this detach आपको दो quick not we can tie आपको दो okay this has to be down okay take it up okay hold this needle take the needle out so this is up and down this give me this one let's hold so you can make a slide not pusher please not pusher in my hand so we are going to take a crisscross so that cutout doesn't take place so I was able to show you the AJ anchor as well.
Yes.
And then closer. You see that it goes and sits into the same place from where we have detached. So this is the last. Then we'll close in layers. I like to close.
Dr. Amit,
Yes, sir.
thank you for your demonstration. Very nice demonstration. I've been told to wind up this.
Thank you very much, sir. This is my last talk, and thank you very much. I'll see you there in Oxford. Thank you very much for listening. Thank you.
Thank you. It was a privilege for us. Thank you, man.
Next. Thank you. That was two wonderful live surgeries by Dr. Nagmani and Dr. Amit Joshi. So next we are proceeding with the scientific session. First session is alignment session 1 and chairperson for the session is Dr. Amit Joshi, who is